A good surgeon is one who knows when not to operate. So a surgeon is not necessarily a man who is just going for the operation or surgical procedure. So always keep in mind that a good surgeon is the one who knows not to operate. So coming back to today's topic, I already shared with you guys the outlines of the topic, and we're going to talk about the thyroid surgery. We're going to talk about a little bit about the anatomy, and then embryology and physiology, and then the details about the surgical procedures or the surgical options we have in case of the thyroid surgery. So first of all, coming to the anatomy, but before that, I'll just like to tell you about a little bit about the embryology of the thyroid gland, how is actually it's originated, or basically the origin of the thyroid gland. So let me tell you that the origin of the thyroid gland is basically the endoderm of the primitive gut, and its original site, you can find it at the back of the neck, which is basically the foramen cecum. And then it migrates down from the foramen cecum, which is present at the base of the tongue, to the anterior neck, just in front of the laryngeal cartilages in trachea. So in the diagram, you can appreciate the other structures as well. This is a submandibular gland, just below the angle of the mandible. So that's why it's called as the submandibular gland. You can also appreciate in the diagram, this is the internal carotid artery, and internal carotid is a branch of the common carotid artery, which is actually it is the core artery which is supplying the vasculature and the structures in the neck. So you can also appreciate this is the internal jugular vein. This is a very important vein because we use this as a central venous access line. So we also have to take care whenever it's performing these operations in the anterior neck or in the lateral to the posterior neck, because it's more likely in posterior lateral compartment of the neck, but we have to take care of these structures as well because they are the central venous lines. And you can also appreciate this is the internal carotid artery, which is running just behind this sternocleidomastoid muscle, and this is a very important muscle of the neck because basically this is responsible for the side-to-side movement of the neck. So there's also the trapezius muscle. You can also see the anterior scalene muscles as well. This is the internal jugular vein, and right here you can also see the common carotid. And I was just telling you a couple of minutes ago that the internal carotid is a branch of the common carotid. And you can also appreciate this is the manubrium at the second costal cartilage, and this is the right common carotid artery, and these are the cricoid cartilage, and the thyroid gland is just in front of the cricoid cartilages and just below this hyoid bone, and this is the omohyoid muscle, and this was the hyoid bone I was talking about. So the thyroid is running just below the hyoid bone in front of the cricoid cartilages. We can also cricoid cartilages, one of the laryngeal cartilages. You can also appreciate the mylohyoid and the digastric muscles, which are also located in the submandibular triangle in the anterior neck. So coming about just talking about the anatomy of the neck, you can also appreciate different structures like left vagus, and then you have this is the left vagus, which is running just in close proximity to the common carotid artery. This is the internal jugular vein. This is the inferior thyroid vein, and this is the left recurrent laryngeal nerve, which is basically passing between the groove, tracheoesophageal groove. You can also appreciate the same structures here on the right side. This is the right vagus nerve, and also you can appreciate about the glands as well. So if you just have a look on this diagram, you can appreciate this is the thyroid gland basically, and we have the right and the left and the right thyroid gland as well, and these are basically connected to each other through an isthmus, which is actually not shown in the picture. And these small glands, which are just located on the posterior surface of the thyroid gland. These are actually the parathyroid glands, and they are very much important for the calcium regulation because they're just stimulating the vitamin D, and they are secreting the parathyroid hormone PTH, which is responsible for the calcium homeostasis. So these are the same structures I've already told you guys. If you look upon this picture, so this is basically the thyroid gland. There's an isthmus which is connecting both right and the left lobes of the thyroid gland, and basically these are the two superior parathyroid and two inferior parathyroid gland. But if we talk about the composition of the thyroid gland, it's actually a colloid, and the whole of the thyroid gland is actually consisting of 20 to 40 follicles which are in the thyroid gland, and these follicles are full of colloid, and colloid has a lot of thyroglobulin, in which the thyroxine and the triiodothyronine, basically these are the hormones of the thyroid gland which are stored here. So talking about a little bit of the physiology of this gland, this is basically the thyroid follicular cell, and within these follicular cells there is a secretion of the thyroglobulin, right? And what happens, like whenever we take dietary iodine, and then the dietary iodine is actually converted into iodide. But coming back to this picture, you can see that there is a thyroglobulin secretion, and then there's exocytosis, and this thyroglobulin, which was initially secreted within the thyroid follicles, that moves out of the follicle because of the process of the exocytosis. And then what happens, like this, there is a sodium iodide syn transporter which actually helps. This is the basolateral membrane of the thyroid follicle, and what happens that dietary iodide, that's basically that dietary iodine is transported through this sodium iodide syn transporter, and then what happens that there's an enzyme which is located inside the thyroid follicular cells, and that's named as thyroid peroxidase. Actually, that helps in the iodination of the dietary iodine that is converted into iodide. And what happens, like this iodine is basically after iodination, it's taken up by the thyroglobulin. There's a conjugation, and monoiodotyrosine and diiodotyrosine are formed. Then what happens that there's endocytosis, and through this endocytosis, this monoiodotyrosine and diiodotyrosine, they are pushed back into the thyroid follicular cells, and then there's a coupling, and then T3 and T4, triiodothyronine and thyroxine, T3 and T4, they are then synthesized, and they're then taken back into the blood. They're then transported back into the blood, and this is how the whole of the process works. So actually repeating all of the thing, actually thyroid gland has a lot of follicles and the colloid, and there's a formation of the thyroglobulin, and then this thyroglobulin is transported out of the cell because of the exocytosis, and then the dietary iodine, which was basically taken through the diet, that was transported into the cell through the sodium iodide syn transporter. And then what happens that this iodine is converted into iodide, and then it combines with the thyroglobulin, and then monoiodine tyrosine and diiodotyrosine, they are basically formed, and then there's a coupling, and there's a pinocytosis or endocytosis, and then these thyroxine and T3 and T4 are formed, and they're transported back into the blood. You can see in the diagram, this is a thyroxine, this is a triiodothyronine, and they're transported back into the blood. Thyroxine is actually T4, and triiodothyronine is basically T3. So T3 and T4, these are the active thyroid hormones which are transported into the blood, and they're basically, most of them are bound to the thyroglobulin, but what happens, like only the active form of the T3 or T4 is the free form, which is the unbound form, and which is not bound to the proteins or albumin or thyroglobulin. So that was the whole of the physiology. So if we talk about the imaging of the thyroid gland, now the question is why we need the imaging modality of the thyroid gland, because actually a patient presents to you with a large swelling in front of the neck, and most probably on examination, if we ask the patient or we demand the patient to actually protrude the tongue, if the swelling is moving on protrusion of the tongue, that is basically a thyroglossal cyst, which is coming from the base of the foramen cecum, right? And what happens, like if the swelling is moving with the swallowing, you demand the patient to swallow, and if the swelling is moving with the swallowing, then most commonly we think about the thyroid. There is maybe a thyroid swelling, a goiter, or just the solitary adenoma, or maybe a colloid goiter as well. So for all those things, you need to have imaging. So if we talk about the imaging of the thyroid gland, the basic modality we have is a chest X-ray. You can see that there is a large thyroid just in the retrosternum. Sometimes it happens that the thyroid, basically the location of the thyroid gland is in the neck, but sometimes the thyroid gland is in the mediastinum. That's we called as a retrosternal thyroid, retrosternal goiter, or retrosternal thyroid. So whenever we ask the patient for the chest X-ray, we are actually ruling out the retrosternal goiter. So if the thyroid gland is in the mediastinum, you can appreciate in the chest X-ray. This is the chest X-ray, and here you can see a large thyroid gland which is actually lying in the mediastinum. To the image A, you can see that this is the ultrasound of the thyroid gland, and you can appreciate here that this is basically the thyroid with the isthmus. This is the right lobe of the thyroid, this is the left lobe of the thyroid, and I already told you in the basic anatomy that the right and the left lobe of the thyroid are connected through the isthmus. So basically this is the right and the left thyroid. You can appreciate you can basically the order ultrasound, which is basically very, very diagnostic, because if there is a goiter or there is a thyroid swelling and you order for the ultrasound, actually what ultrasound is going to tell you? There is increased wall thickness of the thyroid gland. That means this is a hyper-functioning gland, and then you can order some other investigation to rule out about the like adenoma or toxic adenomas, or maybe the simple multinodular goiter. So this is the figure B. This is also basically another image which is taken up by the ultrasound, and already told you this is the chest X-ray. And why we need a chest X-ray? We don't need a chest X-ray to actually to look for the thyroid gland which is in the neck, but for the thyroid gland in the mediastinum, sometimes there's a retrosternal goiter. So to exclude the retrosternal goiter, we have to order for the chest X-ray. So these were the imaging modalities. Or this is again the same. This is again the same image, which is actually showing you the retrosternal goiter. And figure B, this is basically the CT of the CT image, which is a computer tomographic image of the thyroid gland. And you can also appreciate here there is a large thyroid gland which is basically compressing the artery just behind that. This is a CT image, and this is an MRI image. So these are basically the highest modalities, or the invasive modalities. Usually we can make up the diagnosis on ultrasound or the thyroid scan, radionucleotide scanning, or we can make the image on the basis of fine needle aspiration. So this is basically the radionucleotide scan. Now, what is the radionucleotide scan? Basically, there are two scans. One is the ultrasound scan, which is a normal ultrasound, and we use ultrasound probe, and the probe is put just on front of the neck, and then we can appreciate the thickness, the right and the left lobe. I already showed you in the previous slide. But sometimes, to see the functioning of the gland, to see whether there's a hot nodule or a cold nodule. I'll tell you in detail what is a hot nodule or what is a cold nodule later on. But in order to see the functioning of the gland, we order for the 131 iodine. That is basically a radionucleotide scanning. And if there is increased uptake of the iodine, that means the gland is hyperfunctioning, and that is a hot nodule. And if there is a decreased uptake of the iodine, actually you actually order the patient to give a contrast, that is basically iodine 131, and if there is an increased intake of iodine 131, that means the gland is hyperfunctioning, and that is a hot nodule. You can appreciate in the diagram, this is a particularly a solitary nodule. So you can, if there's a hot nodule, there's a less chances of the malignancy, and if there is a less uptake of the iodine 131, so what happens, that means it's a cold nodule. But in cold nodules, which are basically a hyperfunctioning gland, there is a more chances of malignancy. So if you perform a iodine scan or the radionucleotide imaging scan, you can actually know about the functioning of the gland, like it's a hyperfunctioning or hypofunctioning, if there is a hot nodule, if there's a cold nodule, and then you can also predict the risk for the malignancy, because the cold nodules, they have increased risk for the malignancy, but the hot nodules, which are hyperfunctioning, they present to you with the features of hyperthyroidism, and they have minimal risk of malignancy, or you can say there's no risk for malignancy in the hot nodules. So this was all about the basic imaging you're ordering for a patient who is coming to you with a thyroid swelling. Now, if we talk about other things, like there is another modality, there is a fine needle aspiration cytology. But the question is, when are you going to order for the fine needle aspiration? Why and when? That's a very, very important thing to understand. If there are multiple swellings you can found, or you can palpate, and the ultrasound is giving you the impression that there are multiple swellings, and there are solitary nodule, one dominant nodule, or one solitary nodule, you order for the fine needle aspiration cytology. So this is basically the classification. You can appreciate on your screen that if this is THY1, basically this is non-diagnostic. If it is THY1C, this is non-diagnostic, but the swelling, or basically the nodule, is cystic in origin. If it is THY2, it is non-neoplastic. If it is THY3, it is follicular, and if it is TH4, there's a suspicion of malignancy. This is basically the criteria or the classification. I already told you why we order for fine needle aspiration cytology, because if there is a solitary nodule, it can be thyroid adenoma, or maybe it can be a toxic adenoma, or if there are multiple swellings in the thyroid gland, it's a multinodular goiter, but there is a dominant nodule, we have to order for the FNAC, which is a fine needle aspiration cytology, and we have to look for the functioning of that nodule. If it is a hot nodule or cold nodule, we can appreciate it through, or we can have a little bit of the idea through the radionucleotide scanning or the radionucleotide imaging. But in order to have a definite diagnosis, we have to go for the FNAC, which is a fine needle aspiration cytology. So again, I'm just repeating this classification for you guys so you can memorize it well. And this is THY1, which that means it's a non-diagnostic FNAC, or if it is THY1C, it's that's non-diagnostic, but the swelling or the nodule was cystic in origin and there's no suspicion of malignancy. If it is THY2, it's there is no suspicion of malignancy. It's a non-neoplastic lesion, and you can manage it accordingly. And THY3, it's follicular, or THY4, that means there is a suspicion of malignancy. And obviously for all those nodules, or for all those swellings which are on the classification criteria of THY4, there's a suspicion of malignancy, and so they need to be excised immediately. And then there's a THY5, which is actually malignant. In THY4, there is a suspicion of malignancy, but in Thy5, which is THY5, this is actually confidently malignant. So this was about the thyroid FNAC classification. But I already told you there are different modalities. Like you can treat the thyroid disease on the on pharmacological treatment, or you can also treat it accordingly. You can also go for the surgical options as well. You can go for lobectomy, you can go for subtotal thyroidectomy, or you can go for total thyroidectomy. But what is the criteria for selection of a particular procedure? So you have to consider the risk of the thyroid failure, you have to consider the risk of the recurrent nerve injury, you have to think about the risk of recurrence, you have to think about the grave disease, you have to see if it's a multinodular goiter or not, and you have to also appreciate about, like, if it's a differentiated thyroid cancer, there's a risk of a hypothyroidism as well. So let me explain you all these things. Risk of thyroid failure. Sometimes when you perform a total thyroidectomy, and whole of the thyroid gland is removed, whole of the thyroid gland is taken up, what actually happens is there is iodine deficiency. There is a deficiency of the thyroid hormone. So you have to put the patient for lifelong thyroxine. So with the passage of time and with the passage of advancement in this field, people are actually surgeons are preferring to have the subtotal thyroidectomy. Like you have to remove whole of the gland, leaving behind 4 to 8 grams of the thyroid gland, just a little bit remnant of the thyroid gland, so that there is no deficiency of the thyroid hormones, and patients need not to be put on the thyroxine therapy lifelong. So if there's a risk of thyroid failure, so you don't have to take up whole of the thyroid gland, you go for the lobectomy or you go for the subtotal thyroidectomy. And if the cancer, if there's a thyroid carcinoma and it is a very poorly differentiated and it is involving the most of the structures surrounding the thyroid gland, there is a risk of recurrent laryngeal nerve injury, because I already told you that this actually recurrent laryngeal nerve, what happens on the right side, it winds around the subclavian artery, and on the left side it winds around the arch of aorta, and it passes just between the groove, the tracheoesophageal groove. So that groove is just behind the thyroid. So whenever a surgeon is performing a thyroid gland surgery, there is a risk to injure the recurrent laryngeal nerve. So also you have to consider the minimally invasive procedure to actually prevent this injury to the recurrent laryngeal nerve. And risk of recurrence, like if there is iodine deficiency, mostly the multinodular goiter, or they are the puberty goiters, they are the physiological goiters, or there is a risk of recurrence in these as well. But in case of the grave disease, you have to put the patient on a radioactive iodine therapy. Thyroidectomy is not actually the recommended for the grave disease, because grave disease is actually the autoimmune disease. Thyroid gland is functioning, but actually there are the antibodies which are actually destroying all these. So we have to take care of these things as well. So if there's a multinodular goiter, you have to perform the total thyroidectomy to remove the whole of the, because actually in a multinodular goiter there's no distinction, there's no boundary line or the premises you have to follow. So you have to take up the whole of the thyroid gland. In differentiated thyroid cancers, you have to put the patient on thyroid radioactive therapy as well. You have to put the patient on radiotherapy. You have to remove the thyroid gland. So all of these things matter. So whenever you are selecting a procedure, like you have to perform a lobectomy or subtotal thyroidectomy or total thyroidectomy, you have to consider risk of thyroid failure, you have to consider risk of recurrent laryngeal nerve injury, you have to consider for the risk of recurrence, you have to consider for the grave disease, multinodular goiter, differentiated thyroid cancers, and you also have to consider about the risk of the hypoparathyroidism, because in the previous few slides, there was a slide I showed you that on the posterior surface of the thyroid gland, we have the parathyroid glands, two superior parathyroid and the two inferior parathyroid gland. So if you perform a total thyroidectomy, there is not only the deficiency of the thyroid gland, but also there's a deficiency of parathyroid hormone as well, and there's a deficiency of calcium. So you have to put the patient on a lifelong treatment for the calcium supplements as well, along with the thyroxine. So these are the things you have to keep in mind while performing a procedure in a patient who's coming to you with a thyroid swelling or a thyroid disease. So that was the whole of the thing. Now we're going to talk about the thyroid swellings. You need to know how to describe the thyroid swelling. You need to go for the appropriate investigations. You need to know what are actually the indications for the surgery. You need to select the appropriate procedures, and you need to describe and manage the post-operative complication. We are going to discuss these things one by one. First is you need to know how to describe a thyroid swelling. Let's suppose there is a patient and the patient is coming to you and she's telling you that I am appreciating that there is a swelling. It was just a random incidental finding that I found to have this swelling in front of my neck. So you take a proper history, and then you perform a detailed physical examination. And in physical examination, you need to know how to describe a thyroid swelling. But starting from the history of the patient, what are you asking? You need to ask for the symptoms of hypothyroidism, or you need to ask for the symptoms of hyperthyroidism. So what happens that if a patient is hypothyroid, he will tell you that there's a history of weight gain, or he will tell you that there's a generalized edema. There's a swelling, and whenever he gets up in the morning, there is basically the puffiness of the eyes, there's a puffiness of the eyelids, and there's a facial swelling as well. So if a patient who is hypothyroid, he will tell you that he has symptoms of constipation, he has symptoms of weight gain, and he has basically cold intolerance. So hypothyroid patient will give you this history. But if a patient is hyperthyroid, there is an increased functioning of the thyroid gland, he will tell you that there is a history of weight loss, there is a history of increased appetite, there is a history of weight loss, and he's also going to tell you that there is an excessive sweating, or there is a heat intolerance as well. And he's also going to tell you about the weight loss as well, increased appetite and diarrhea, and obviously he is thin, he's lean. So this is basically a person who is coming to you with the symptoms of hyperthyroidism. So this was the thing you need to ask in the history, and then you will ask the patient, you will examine the patient. What you're going to look, you will ask the patient to protrude his tongue to see if the swelling is a thyroglossal cyst or it's a thyroid swelling. If the swelling is moving in protrusion of the tongue, this is basically a thyroglossal cyst. Or if the swelling is moving with the swallowing, you ask the patient to swallow, and if the swelling is moving with swallowing, then this is basically a thyroid swelling. Now you have to actually inspect, and then you have to you need to appreciate if there's a hoarseness or basically the pulmonary insufficiency, or there is a shortness of breath as well. So you need to ask all these things in the history as well, and you need to inspect, and then you need to palpate. And the palpation, what are you going to look for? You need to measure the size of the swelling. You need to have a consistency. You need to feel the consistency, if it is solid or cystic. There's one swelling, or there are multiple swellings as well. And then you have to obviously check for the skin fixity as well, like the swelling is fixed to the skin, or the swelling is fixed to the deeper structures. You have to look for the mobility of the swelling as well. So you need to know how to describe the thyroid swelling. You will tell that there's a discrete swelling, this to this centimeter, or this to this inches in size, and it's fixed to the skin, or it's fixed to the deeper structures. Or if there is associated symptoms, like if the swelling is very big, it's actually actually compressing the structures just behind that, because it can actually involve the recurrent laryngeal nerve, and if there is a unilateral recurrent laryngeal nerve involved, the patient will complain about the hoarseness, and if there is a bilateral recurrent laryngeal nerve involvement, the patient will complain to you about the sharpness of the breath, and there will be pulmonary insufficiency, right? So if they already discussed to you about the retrosternal goiter, the thyroid, which is actually in the mediastinum, so how are you going to differentiate that? You need to ask the patient to lift up his hands just above the shoulders, fully extend the arms just above the shoulder. This is called as a Pemberton sign. And if there's a congestion of if there's a congestion of veins on his face, you can appreciate that there's a retrosternal goiter, which is actually compressing the trachea just in the mediastinum. So that's how you need to perform the detailed history. You need to perform the detailed physical examination, and then you need to use the appropriate investigation. You'll order for the thyroid scan, you'll go for the ultrasound imaging, or maybe CT MRI. They're basically very invasive. So if there are multiple discrete swelling and there's a dominant nodule, you'll go for the fine needle aspiration cytology. Then already you should know the indications for the surgery, like you need to perform the surgery if the patient is hyperfunctioning. If the patient is hyperfunctioning, or if the patient is under hyperthyroidism, there is increase in free T3, T4, but there is a decrease in TSH levels. If such patient is coming to you, that's mean he's in a hyperfunctioning state. So first, what you need to do is you need to bring down his levels. You need to actually control the free T3 and T4 levels. So you will put her or him on a pharmacological therapy on carbamazole or propylthiouracil basically, or methimazole basically. So, and you also need to give beta blockers, because whenever the patient is hyperthyroid, there is palpitation, increased heart rate. So you need to control the symptoms as well. So what do you need to actually put the patient on a pharmacological treatment, and you have to put the patient on propylthiouracil or methimazole, which is basically the carbamazole, and also you have to give the beta blockers to the patient. So basically, and then when the levels are normal, the patient is in a euthyroid state, then what actually you do is then you perform the surgery for the multinodular goiter. And then you also select the appropriate procedure, like what procedure you need to perform on a patient, like lobectomy. If only one lobe of the gland is involved, there's a nodule, there's a toxic solitary nodule in just the right lobe of the thyroid, you'll just perform the lobectomy. There's no need to take up a whole of the thyroid gland and putting the patient on a lifelong thyroxine therapy, or putting the patient on calcium supplements, because if you're performing a total thyroidectomy, you're actually removing the parathyroid glands as well. So you need to make a decision, and you need to go for appropriate procedure in a patient according to the disease or the symptoms. And then describe and manage the post-operative complication. This is very, very important. I'll tell you what post-operative complications you can have in a patient. There can be hemorrhage, there can be recurrent laryngeal nerve injury. Some complications are basically, you can say, initial complications, and then there are late complications. So what are the initial complications, or what are the late complications? We'll discuss in detail in few slides. So this was about the thyroid swelling. Let me classify this for you. Thyroid swelling can be a simple goiter, which can be, if the simple goiter, euthyroid. What is a euthyroid state? That means that T3, T4, and TSH levels, they're normal. They're not hyperfunctioning. They're not hypofunctioning. This condition is called as basically a euthyroid state. But the question is, if there's a large swelling in the anterior compartment or the anterior triangle of the neck, and you're suspecting a thyroid swelling, or maybe some kind of pathology in the thyroid gland, So, how can be a patient in a euthyroid gland? Actually, there's some of the follicles which are hyperfunctioning, and there's some of the follicles which are hypofunctioning, right? So, as a whole, the gland T3, T4, TSH level, they're actually in the normal range, because some are hyperfunctioning, some are hypofunctioning, so they balance each other. So that's how the patient is in a euthyroid state. So, if this is a simple goiter, it can be diffuse hyperplastic, or it can be a multinodular goiter. If sometimes it can be the thyroid swelling can be a toxic, it can be diffuse again, it can be a multinodular, or it can be a toxic adenoma. And there is another category, which is the neoplastic. And you have benign and the malignant, and in benign you have the adenomas, but in malignancy you have the follicular carcinoma, you have the papillary carcinomas. Basically there are a lot of malignant carcinomas which are actually invading the deeper structures, and that's why they're called as malignant. So again, looking upon this classification, you have the thyroid swelling. It can be a simple goiter, it can be a toxic, or it can be a neoplastic. But there is another classification which involves the infective pathology as well, because there can be a thyroiditis, right? It can be a autoimmune Hashimoto thyroiditis. It can be a dequerent thyroiditis, which is called as a subacute thyroiditis. So basically, that is the infective etiology. So if we talk about the simple goiter, it can be a diffuse hyperplastic, it can be a multinodular goiter, or in case of toxic, you can have diffuse, you can have multinodular, or you have a toxic adenoma. And in case of neoplastic, it can be benign or it can be malignant, like follicular adenomas or papillary adenomas or follicular carcinomas or malignant carcinomas. I will have another lecture in which I'll talk about this neoplastic origin or neoplastic conditions in the thyroid. But today we are just discussing about the simple goiter, and we're going to talk about the toxic swellings as well. And there's another inflammatory, I told you, autoimmune and granulomatous diseases, or maybe a fibrosing or an infective etiology, right? So this is a very, very nice flow sheet. It can help you understand what kind of pathologies are taking place in the thyroid gland. So you need to understand it very nicely, right? So moving on to the next slide, we're going to talk about the simple goiter. This is basically a simple goiter, and it can be, I told you that it can be basically a physiological goiter or a pubertal goiter, or it can be because of the iodine deficiency. Most of those people who are living at high altitudes or they're living in peripheries, they have an iodine deficiency. And what happens that because of the iodine deficiency, some of the glands, they basically swell up, there's increased deposition of the colloid, and actually the glands start hyperfunctioning, but there is no iodine actually to be to make the thyroid hormones. Because if you recall that physiological diagram I showed you guys, there was actually iodine, dietary and it was then converted into iodide, and it was then coupled with the thyroglobulin, and it was incorporated into the thyroglobulin, and then that's how monoiodotyrosine, diiodotyrosine, and then T3 and T4 were formed. But what happens if there's a thyroglobulin but there is no dietary iron, then there's no dietary iodine which is coming from the diet. So what happens? The gland is hyperfunctioning, but there is no iodine to make up the thyroid hormone. So that's why the colloid and the whole of the material is actually assembling in, and this is a simple goiter presentation, and patient will come to you and tell you that I have swelling since 5 months, 6 months, or maybe a year, or maybe sometimes some people don't appreciate, and others tell them, oh, what happened? I can see a swelling, it's just the anterior compartment of your neck. So that's how the simple goiter presents. Already told you, simple goiter can be diffuse hyperplastic goiter, or it can be a multinodular. So this is basically a diffuse. This is the right lobe, or this is the left lobe, and here was the isthmus. So you can see that there is hyperplasia of both the lobes of the thyroid gland. You can appreciate in the diagram. This is called as diffuse, because This not confined to some of the parts and not confined to right or left. Whole of the gland is involved diffusely. So that's why this is called as diffuse hyperplastic goiter. And then you have the nodular goiter. This is a nodular goiter. You can actually see that the swelling is involving the right and the left lobe of the thyroid. But on the right side, you can appreciate a big, massive nodule, which is actually on the right side of the gland. That means it's involving the right lobe of the thyroid gland. You can also appreciate here's also a nodule, but the nodule is actually smaller than the nodule on the right side. You can also see the enlargement of the isthmus, but these are basically three large swellings, but their sizes are obviously different from each other. If you compare it with the previous diagram here, the hyperplastic one, you can see that there's a diffuse enlargement. You cannot appreciate any nodules. The whole of the symmetry is actually proportional to each other on the right and the left side. But here there is asymmetry, and there is more of a nodular goiter on the right side as compared to the left. So this is called as a nodular goiter. This is actually, if we talk about the diffuse goiter, or if we even talk about the multinodular goiter, what happens is they're basically mostly in a euthyroid state. Some of the glands are hyperfunctioning, some of the glands are hypofunctioning, and as a whole there's a balance, and there's no increase in T3, T4 or decrease in the TSH levels. So this was about basically the simple goiter. So there's another, what if it's a massive goiter, and obviously I told you there's a trachea which is passing just behind. So what happens that it can cause a tracheal obstruction. This you can appreciate in the diagram. This is actually the nasal passage, oropharynx, and this is basically this is the oropharynx, this is the nasopharynx, and it's coming deep down into the trachea. There are the tracheal rings, and the thyroid is just lying in front of the tracheal rings, and this is a massive swelling in the thyroid, or a goiter, which is actually, this is the compression, this is the obstruction. So what happens that if the massive giant swelling is there in the anterior compartment of the neck, likely originating from the thyroid, it is actually compressing the trachea, and patient may have acute respiratory obstruction, right? So this is very, very important to know that if there is a large swelling compressing the trachea, there can be acute respiratory obstruction. It can be a complication of goiter. So if you talk about the surgical options, if we have in a goiter, you can perform a thyroid lobectomy, you can go for the subtotal thyroidectomy, or you can go for the total thyroidectomy, right? In thyroid lobectomy, it's actually from the lobe, right? You're actually excising a lobe, you're actually removing a lobe, or maybe a right lobe or maybe a left lobe, depending upon the pathology. If it is in the right, you're going to remove the right one, and if the pathology is in the left, you're going to remove the left, right? So in thyroid lobectomy, you just remove one side or one lobe of the thyroid, and you leave the other one intact. In subtotal thyroidectomy, almost 1/4 of the gland is removed, and only a remnant of 4 to 8 grams. Some books say that you have to leave 8 grams of the thyroid behind, and the rest of the thyroid is taken out. But some say that the limit is between 4 to 8 grams. So you can leave. It's up to you. You can leave 4, you can leave 6, or you can leave 8 grams of the thyroid, and the rest of the thyroid you have to remove. Why we do perform the subtotal thyroidectomy? Already discussed, because if there is a risk of hypoparathyroidism, or if there is a risk of the patient you don't want to put the patient on thyroxine for lifelong, or you don't want to put the patient on calcium supplements for lifelong, you actually leave some of the thyroid and you perform the subtotal thyroidectomy. And in some patients, depending upon if there's a multinodular goiter, there's a diffuse hyperplastic involvement of the goiter, then obviously you don't have any option. You cannot leave any part because there can be recurrence. So you can actually take out whole of the thyroid gland, which is called as a total thyroidectomy, right? So there's another diagram for you guys. You can see a healthy thyroid. These are the lobes of the thyroid with the isthmus. And you can also appreciate that in the next diagram, this is a hemithyroidectomy or subtotal thyroidectomy. And this is basically the isthmus and the lobe, which is left behind. This is a lobectomy, and one of the lobe along with the isthmus. You can also say that this is lobectomy with isthmectomy, because one of the lobe and one isthmus is removed, right? But in hemithyroidectomy, you keep one lobe along with the isthmus, but in lobectomy with isthmectomy, you remove the lobe as well and you remove the isthmus as well. And in total thyroidectomy, what you do is you take out whole of the thyroid gland, right? So these were the treatment modalities. There's another diagram you can see about the total thyroidectomy. Actually, this is the thyroid gland, these are the parathyroid glands, and you remove whole of the thyroid gland along with the parathyroid. But if you look at the other diagram, this is basically the thyroid gland before total thyroidectomy, and this is a gland after total thyroidectomy, actually, and these are the parathyroid which are left behind. Okay, and then you can appreciate the subtotal thyroidectomy. Here's the external branch of the superior laryngeal, and it's actually just in close proximity to the superior thyroid artery. Superior thyroid artery is a branch of external carotid, and the inferior thyroid artery is actually the branch of thyrocervical trunk. So the superior laryngeal is actually following the superior thyroid artery, and recurrent laryngeal nerve is actually just in close proximity to the inferior thyroid artery. So whenever you are performing something with you are ligating inferior thyroid artery, or you're ligating the superior thyroid artery, there's a damage, there's a risk of damage to the either external branch of the superior laryngeal, or you can also damage recurrent laryngeal, but there's a more risk to damage the recurrent laryngeal as compared to the superior laryngeal nerve. So in subtotal thyroidectomy, you have to take care of these things. There's another diagram. You can see that before lobectomy and after lobectomy, there is one lobe of the thyroid which is being removed, and parathyroid are actually intact. So what are the side effects and complications of thyroidectomy? Because it's a very time-consuming operation, or it's the minimum time for the surgery is maybe 2 to 3 hours. So, but actually you're keeping the neck for a whole of the 24 hours in an extending position. So you feel neck tension, and you immediate complications you can have is a neck tension, neck tenderness. There can be voice problems. Why the voice problems? Because if there is a damage to the recurrent laryngeal nerve, actually the patient can have a hoarseness, because if the right side unilaterally recurrent laryngeal nerve is damaged, there's a hoarseness, and if bilaterally you have damaged they both sides of the right and the left recurrent laryngeal nerves, the patient can present to you with the respiratory symptoms and respiratory insufficiency. There can be irritated windpipe like the trachea. There can be irritation in the trachea. There can be swallowing problems as well, and other complications. These are basically the immediate complications, and there can be a hematoma. Why there can be a hematoma? Because actually you're performing a very, very important dissection, and there are a lot of the major vessels that if you remember the diagram I showed you, there's an internal carotid going out there. There's a internal jugular vein as well. There's a superior thyroid artery. There's inferior thyroid artery. So what happened? There can be a hemorrhage post-operatively. So in order, sometimes people, some surgeons put a drain while performing the thyroidectomy, because if there's a hematoma or there's a hemorrhage, the blood will drain out of that, and the hematoma, there will be no hematoma. But sometimes If the drain is not put, the patient can have a hemorrhage and he can present to you with a hematoma. So this is the complication. How you're going to manage that hematoma, actually, because you have to reopen if there is a massive hematoma, and you have to reopen, and then you have to actually dislodge the hematoma. You have to find out the site of the bleeding. You have to apply the suture there. You have to secure the hemostasis. That's how you're going to manage the hematoma. Or you can also perform the tracheostomy as well. If there can be a decreased parathyroid hormone activity, and there can be a recurrent nerve injury. Why there's a decreased parathyroid hormone activity in lobectomy? In subtotal thyroidectomy, there's decreased risk of actually this insufficiency of the parathyroid hormone. But in total thyroidectomy, you remove all of the thyroid gland with the parathyroid, which are actually just on the posterior surface of the thyroid gland. And obviously, when the whole of the thyroid gland is taken up, parathyroid also removed, and there's a deficiency. So especially in case of the total thyroidectomy, and then you have to put the patient and a lifelong calcium supplements. But there is a management you perform to 24 to 48 hours. You need either put the patient orally on calcium carbonate, or you have, if there is an immediate insufficiency of the parathyroid gland, you have to actually dilute the 6 ampoules of the calcium carbonate, 10% calcium carbonate in 500 ml of 5% dextrose water, and you have to give it to the patient at 1 mg per hour, right? 1 ml per mg per hour. And this is how you're going to manage the emergency, because you have to put on the intravenous calcium therapy. And there can be a recurrent laryngeal nerve injury, there can be a bilateral injury or unilateral. If there's a unilateral injury, there's a hoarseness, or if there's a bilateral injury, there's acute respiratory obstruction. So you have to open the patient again, and you have to secure that as well. So thank you for watching. I hope so you like this lecture and you learn a lot, and keep watching sqadia. Thank you.